Most births are these beautiful, pretty straightforward events. But what happens when they're not? When things take a sharp, unexpected turn, a medical team has to rely on this incredibly precise playbook, making split-second decisions that change, well, everything. So today, let's open up that playbook and explore the critical choices doctors face when the clock is ticking.
All right, we're going to look at 4 different case files. We'll start with what happens when a baby's just facing the wrong way. Then we'll see what a sudden, dangerous stop in labor looks like. After that, a physical block. And finally, how doctors can make a preemptive call to stop a crisis before it even starts. Then we'll tie it all together with the playbook itself.
So let's open our first case file, a wrong turn. This is a situation that's actually pretty common, but it can be a huge challenge when the baby's position just isn't cooperating.
Okay, so here's the scene. Labor is moving along, but then it just stalls. Mom's been pushing for 2 hours, and there's just no progress. And the reason? The baby is in what's called an occiput posterior position. All that really means is they're face up, looking at the ceiling, instead of face down. And that little difference makes it way, way harder for the baby's head to navigate the birth canal.
The team has to do something. So what's the very first play they should run? What's the #1 go-to intervention for this exact problem?
The playbook has a really clear step-by-step logic. You always start with the least invasive thing first. So step 1 is to go in and fix the actual problem. Try to manually rotate the baby's head into the right position. If that doesn't work, okay, you move to step 2 and consider some help from delivery tools. And only if that also fails do you move to the final option, a C-section.
Now, this is where the strategy gets really smart. You might think, why not just use a vacuum to help? Well, because trying to use tools when the baby is in the wrong position is not only less likely to work, it's actually riskier. The brilliant move here is to fix the root cause, the baby's position, first. It's just a perfect example of elegant, effective problem solving. Okay, let's move on to our next case, and here the stakes get a whole lot higher. We're going from a common problem to a very rare but absolutely catastrophic emergency. We're calling this one a sudden stop.
So imagine this. Labor is going fine, contractions are strong and regular, and then they just stop, cold. This is immediately followed by severe, intense abdominal pain, and then you see a sudden, sharp drop in the baby's heart rate. This exact sequence of events is a massive red flag for uterine rupture, and that is a 5-alarm emergency.
But wait a second. Other complications can also cause pain or distress for the baby. So in that chaotic, high-pressure moment, how does the team know for sure that this is a uterine rupture and not something else? And this is where the art of diagnosis really shines. It's all about pattern recognition. See, if it were a placental abruption, you'd expect to see bleeding. If it were an amniotic fluid embolism, you'd see major breathing and blood pressure problems for the mother. But a uterine rupture has one single, unmistakable signature. The contractions completely and suddenly stop. That's the signal. That's the alarm bell that tells them exactly what they're dealing with.
All right, on to case number 3, a physical block. This is one of those heart-stopping moments that can happen right at the finish line of delivery, where everything seems totally fine until suddenly it's not.
The medical term for this is shoulder dystocia. And it's really a mechanical problem, a physics problem. The baby's head is out, but one of the shoulders gets physically hooked behind the mother's pubic bone. The baby's literally stuck. Now, this is incredibly time-sensitive. Every second counts. The team has to act right now. So what's the immediate go-to life-saving maneuver that the playbook calls for? The answer is a move that's so simple, it's genius. It's called the Mick Roberts maneuver. All they do is have the mother pull her knees up tight towards her abdomen. This simple motion actually rotates her pelvis and changes the angle just enough to free that stuck shoulder. It's not about force, it's about physics. An absolutely brilliant anatomical solution to an anatomical problem. Now, just as important as knowing what to do is knowing what not to do. And in this situation, the playbook is crystal clear. You absolutely do not apply fundal pressure. That means no pushing on the top of the mother's belly. The natural instinct might be to try and push the baby out, but that can actually jam the shoulder in even tighter and cause a serious injury. This is one of the most critical don'ts in the book. Okay, for our final case, we're going to flip the script a little bit. We're moving away from reacting to emergencies in the moment and into the world of preventing them from ever happening. This is the preemptive call. So here's our scenario. We have a mother with gestational diabetes. Now, it's a known risk factor that this can lead to bigger babies. As she gets close to her due date, an ultrasound confirms what they suspect. The estimated fetal weight is high.
And here's the number that changes the whole game: 4.5 kilograms. That's nearly 10 pounds. This officially classifies the baby as macrosomic, which is just the medical term for a very large baby. And in this situation, it skyrockets the risk of that same emergency we just talked about, shoulder dystocia.
So notice, we're not in an emergency yet. They have the data, they can see the risk on the horizon. The question now is a strategic one. What is the absolute safest plan to bring this baby into the world?
And the playbook is very clear. For this specific high-risk combination of factors, the safest path forward is a planned elective C-section. Why? Because attempting a vaginal delivery or a trial of labor carries such a high risk of the baby getting stuck. The right call is to prevent a potentially traumatic situation altogether.
So we've looked at these 4 very different cases. Let's zoom out. What are the core ideas? What are the key principles that tie all of these decisions together in the doctor's playbook?
When you look at all of them together, you see these guiding principles emerge. You always start with the simplest, least invasive fix, like the manual rotation. You use pattern recognition to make a fast, accurate diagnosis, like with the uterine rupture. You understand the why behind a maneuver, not just the how, like with the McRoberts. You know what not to do, like applying fundal pressure. And finally, you use data to get ahead of the problem and prevent an emergency before it ever has a chance to happen.
At the end of the day, what does this all tell us? It tells us that modern obstetrical care isn't about guesswork or hoping for the best. It's a system. It's a methodical, step-by-step approach to solving problems, where every single choice is designed to lead to the safest possible outcome for both mother and child.
These incredible medical playbooks are being refined all the time, and they save lives every single day. And it leaves you with this amazing question. As science, data, and even AI get more powerful, what does the next chapter of this playbook look like? What new strategies will we discover to make childbirth even safer?